Hello, everyone. Happy Thursday, and thank you all for joining us. My name is Ahmed Mohamed, and I am a manager of public education and civic engagement at the New Pride Agenda, a cutting-edge statewide LGBTQ nonprofit focused on LGBTQ rights and protections for those made most vulnerable in our community through advocacy and education. NPA has been hosting a series of virtual town halls since April 2020, and today's event, all about PrEP in the Bronx, is a part of that programming agenda and co-sponsored by our friends at Amida, a nonprofit community Medicaid health plan designed to provide specialized, coordinated care to New Yorkers who are affected by HIV. Today, we'll be talking about access, dispelling myths, and local resources regarding HIV prevention and PrEP, a once daily pill that prevents from getting infected. This month is also Women's History Month, and National Women and Girls HIV AIDS and Awareness Day was March 10th, a day to raise awareness about the impact of HIV on women and show support for women living with HIV. Because of this, we'll be paying particular attention to HIV prevention for women and girls, both transgender and cisgender. So before we begin, I would like to take a second to introduce our panelist. I'll give the panelists his name and have them take a couple seconds to talk about their work as it relates to PrEP. So first, we have Alister Rubenstein, who works at Amidacare's Transgender Health Program as Amidacare's Transgender Health Program Manager. Alister, could you please introduce yourself, your pronouns, and say a few sentences about your work as it relates to PrEP?
Absolutely. Good afternoon. My name is Alister. My pronouns are they, them. My assistant, Wiley, he, him pronouns for Wiley. So I work at Amida as the Trans Health Program Manager. I've been doing that for almost 5 years. And so Amida is historically an HIV special needs plan. We provide coordinated services to people living with HIV. But in 2017, the Department of Health expanded that model to include other individuals that are put at high risk for HIV, including trans individuals and homeless individuals. So that's really how I got involved in HIV prevention work. So that looked like building out an HIV risk assessment, making sure we're outreaching all of our members to make sure that they're aware and educated on PrEP and PEP and that they have access to it. And our data is starting to come in, and what we're seeing is that we have been successful in starting people on PrEP who weren't before on PrEP. And the education thing is a big thing. So I look forward to talking more about it. And thank you so much for having me.
Thank you. Thank you so much, Alister. I want to acknowledge, I see that we have Councilmember Vanessa Gibson joining us. Councilmember, we're just wrapping up introductions, and then if I could return to you for opening remarks, you'll have the floor for 3 to 5 minutes. But next, I would like to introduce Dr. Jay Ahn. Dr. Ahn is the Chief Medical Officer at Union Community Health Center. Dr. Ahn, do you mind giving us your pronouns and again, a little bit about your work as it relates to PrEP?
Sure. Good afternoon, and my name is Dr. Jay Ahn. My preferred pronouns is she and her. I'm very happy to be here to basically talk about PrEP and how we are providing PrEP for our community at Union Community Health Center via our walk-in clinic as well as our primary care clinics. So we want to have very broad access to everyone that is at risk for HIV infection so that they have the proper prevention medication, Truvada, which is very highly effective for the treatment and prevention of HIV.
Thank you. Thank you so much, Dr. Ahn. Next, Nathalia Gibbs from Harm Reduction Coalition. Nathalia, do you mind introducing yourself, pronouns, and again, a little bit about your work?
Hi, yeah, can you hear me? Yeah, okay. So yeah, my name is Nathalia. I use they, them pronouns. I'm at the National Harm Reduction Coalition, where I do a lot of work specifically to do capacity building and technical assistance to make harm reduction more accessible to queer and trans folks, and make more spaces for queer and trans folks who use drugs to be able to do so safely. And part of that involves folks having the information they need around PrEP.
Thank you so much. And last but definitely not least, Sage Rivera, Director of Programs for Destination Tomorrow based in the Bronx. Sage, again, your pronouns and a little bit about your work.
Good day, everyone. My name is Sage Rivera, and I'm the Director of Programs, as Ahmed said, for Destination Tomorrow, the Bronx LGBTQ Center. So that goes us right there. And basically, it's my privilege to be here. Here at us as a center, we take a comprehensive approach to all the services that we provide. And as they relate to PrEP, we do a variety of things within our prevention department, everything from HIV counseling and testing to providing referral-based resources to individuals that want to go into PrEP treatment and things like that. We also manage a program called Transcend, which provides resources to trans service agencies for people of color all over the country. And we provide navigation services for treatment adherence for those who are undergoing treatment within the PrEP scope. So do a lot of things that also deal with the cofactors to prevention and keeping the community healthy. So it's a pleasure to be here. I'll try to get over my nerves as time goes on, but thanks. And my pronouns are they, them, theirs, and when I'm in this form, he, too.
Thank you. Thank you so much, Sage. Thank you to all the panelists. I'm excited to learn more from you all as we dive into some of the questions. But like I said before, we are joined by a special guest. Councilmember Vanessa L. Gibson proudly serves the Bronx 16th Council District. As the West Bronx voice at City Hall, she passionately advocates for affordable housing, low-income families, seniors, LGBTQ rights, gender equity, employment access, and meaningful opportunities for our youth, a multi-hyphenated icon representing the Bronx. So I'll hand it over to Vanessa L. Gibson. Councilmember Gibson, the floor is yours.
Thank you so much, Ahmed, and good afternoon, everyone. It's a great honor to join with all of you. I am New York City Councilmember Vanessa Gibson of District 16 in the Bronx. I welcome each and every one of you to our webinar today, all about PrEP virtual town hall with a special focus on National Women and Girls HIV/AIDS Awareness Day and resources in the Bronx. My pronouns are she, her, and hers, and I thank you all for being here today. Thank you to New Pride Agenda, to Amida Care, Union Community Health Center, Destination Tomorrow, and Harm Reduction Coalition. My partners, my friends, my allies, I love and appreciate each and every one of you. And over my 8 years in the City Council, it's really been an honor working together with all of you. Last December, our council office partnered with Visiting Nurse Services of New York and other community organizations and providers for a World AIDS Day event to highlight the advances that we've made in HIV/AIDS prevention, the medicine and support for New Yorkers living with HIV/AIDS. It was a cold day, December 1st, but we had a great event. It was amazing. A lot of people came out. We were in Behagan Playground in Morrisania, and I'm really grateful. We had COVID-19 testing. We had lots of information available for residents. Unfortunately, the Bronx continues to have some of the highest rates of HIV diagnosis in the city, with my district, Morrisania and Highbridge, accounting for a majority of those diagnosed cases in 2019. This is in part a result of unequal access to HIV prevention and care services in many low-income zip codes like the ones that I represent, the 10452, 10456 zip codes. Not enough attention is given to how HIV/AIDS impacts our women, specifically women of color. 1 in 5 new HIV diagnoses are among women, and 9 in 10 of these are African-American women and Latina women. These are our sisters, our mothers, our aunties, our grandmothers, cousins, friends, neighbors, whose stories are not being told because of the stigma, the stereotype that still persists around HIV/AIDS. It's unacceptable. We need to also ensure that our transgender community is included in these conversations. In 2019, 52 transgender individuals were newly diagnosed with HIV and 26 deaths. Many of them, again, African-American and Latino New Yorkers. I am proud of the New York City Council, my Women's Caucus. We've done a lot of work. We've partnered and funded, right? You can't just talk about it, you have to be about it. So we've funded organizations such as COPE, Amida Care, Destination Tomorrow, that are on the ground, on the front lines, every day, all day, making sure that our residents get the care that they rightfully deserve. You can find free or low-cost confidential HIV testing locations by checking the NYC Sexual Health Clinic locations, the hours and available services at nyc.gov/health/clinics, or you can text TEST, TEST, NYC to 877-877, and you can call 311. And so again, I look forward to today's conversation. I thank all of you, our community partners, for all of the work you've done around education, outreach, promotion, and access. Access and opportunity is truly where we need to be. We have to talk the talk, but we have to walk the walk. We have to be about it. We have to be change agents in our communities. No matter what title you have in front of your name, we are all called to serve in some way. And most importantly, we are doing this work for the next generation of young people that are looking to us. We are their role models, and you can't be what you can't see. Our young people need to see us doing this work. No matter who you are, how you identify, who you love, we don't care. We love you anyway. And I want to thank all of you for your compassion, for your conviction, for your commitment, for standing in your purpose. You see how excited I am. I'm passionate about this work because it is unacceptable that our district, our borough, has the worst distinctions all the time. We are tired of that. And so I appreciate all of your efforts to end racism, discrimination, inequity in healthcare. We have to promote racial equality and social justice. And so I thank all of you. Thank you, Ahmed. I want to thank also my director of outreach and my LGBT liaison. He does it all for me. Michael Ivory. Thank you, Michael, for everything. I appreciate you. We love you. We support you. And let's keep up this great work. God bless everyone.
Thank you. Thank you so much, Councilmember Gibson, for those words. Those powerful, inspirational words. What a way to set the tone. Hopefully we can keep that going for a lively, engaged discussion. I truly appreciate you joining us. I know you're pretty busy, so thank you again. And before we get into having a discussion, I just want to set some ground rules in the hopes of being as interactive and engaged as possible, just making sure that everyone is on the same page regarding mutual respect. We encourage everybody to practice actively mutual respect when listening and talking to others. Of course, this is a community setting where we hope everything that's shared is confidential. It will be recorded, but if there's anything that you don't want to be on a recording going public, you could of course let anybody on New Pride Agenda or MediCare's team know, and we'll take care of that. And then lastly, we want this to be interactive and hear from you all, but we encourage you folks to use I statements when making comments. I've read, I've seen, I've heard, just so that we could all be approaching the discussion from the same place of respect. But without further ado, I think it's time to jump into some of the content for today, PrEP 101, if you will. And I guess it would be good to just level set. I know some folks in the audience do a lot of work with PrEP on a regular basis. Some may not know about it. So Dr. Ahn, I would like to come to you first. If you could describe what PrEP is for those in the audience who don't know what it is. I think you might be muted.
Unmute myself. Okay, sure. I do have a couple of slides. I don't know if that would be good for our group, or I could just talk about it. PrEP, it's basically pre-exposure prophylaxis for the prevention of HIV infection. So this will prevent you from getting HIV if you use this daily medicine. Currently, there's 2 drugs that's got FDA approval for PrEP. Truvada, which is the most known drug. It it was approved in 2012 and we have the most data on Truvada, and it's effective in all groups. And then the more recent is Descovy, similar drug made by Gilead, but that drug has less information and is limited because we don't know its efficacy or effectiveness in people that use that get exposed to HIV while they inject drugs or have vaginal sex. So which is very important because right now we're focusing on women and preventing HIV infection in women that are at risk because they are disproportionately affected by HIV infection, definitely in the Bronx. So I'm going to talk more about Truvada, and also Truvada has much better coverage with insurance companies, and it's much readily available, as well as actually there's a generic form which has much better coverage as well. So if patients that have an issue, if co-payments or their insurance, it's actually pretty relevant, these details of how to get access to the medication. Currently, most insurance companies will cover it, I would say, with a prior authorization. Truvada is 99% effective in preventing HIV infection if used daily and consistently. It's very well tolerated, meaning there's very few side effects. The most common side effects are gastrointestinal, like nausea, vomiting, and upset stomach, but pretty much well tolerated, and the side effects go away within 2 to 3 months. Most people, they're called like initial side effects, which basically your body sort of gets used to it and they dissipate. The question that a lot of people say, like who should we offer PrEP to? Actually, it's pretty much anybody that uses, engages in sex without condom use. But the higher risk groups are men that have sex with men, people that use injection drugs, actually people with multiple sexual partners, and adolescents, because they may be more inclined to have multiple partners. And people that are also at substantial increased risk for HIV infection are people that have a history of sexually transmitted diseases in the past. And sex workers or individuals that are engaged in this like work for sex for money or drugs or housing. And then the main reason why basically anybody would qualify for PrEP is inconsistent condom use. And pretty much almost anybody that is sexually active, that does not consistently use condoms, is a candidate for PrEP, especially if they are not in a monogamous relationship and they are candidates for PrEP.
Mm-hmm.
I'm going to just pause there for a second because I just said a lot.
No, I appreciate that a lot. Thank you for walking us through that, especially the different nuances between the types of drugs. I find myself learning new things with each iteration of these events, and we'll definitely return back to you to get more of a clinical perspective in other contexts in a second. And before we dive into sort of our focus on women and health, I also want to provide some context about the state of play in the Bronx, if you will. So Sage, as director of programs for Destination Tomorrow, if I could come to you, if you could describe, just given your long history of community work in the Bronx, how would you assess the community's progress in PrEP uptake, and what are some of those barriers that still remain, those persisting barriers?
I would assess the community's progress around PrEP is that there's definitely progress in awareness. There is a sort of like increase in the commonality of knowledge of people being aware of what PrEP is and what it does. But as far as the upkeep or just engaging in PrEP treatment, there are some disconnects there, and it has to do with various cofactors into accessing PrEP or just in that statement alone, various cofactors in accessing PrEP. Cofactors around socioeconomic status, that includes housing, that includes having competent and conscious places to go to for healthcare, and not only physical healthcare, but definitely mental health care. And it's something that we find a lot here because, being a community center, we center around, like I said, in a comprehensive way, addressing the needs that are client centered and building up the person because if I don't feel good, then I don't have any self value. And creating self worth leads to self care. And having PrEP as a person's care plan is only going to work when I'm feeling better about myself. And what we have found is, there are different barriers that I could speak at length about, especially when it comes to access to things around behavioral health and housing or even food insecurity, which are things that are probably more pressing on our community's needs than getting a new medication that I may have difficulties accessing depending where I go. So that's just a little bit on it right now in our experience here at the community center.
No, I thank you for sharing that. I think it makes intuitive sense when you're dealing with all these stressors that a pill falls further on the list of things that you need to accomplish. And your point about self-worth and self-determination and giving the patient the power to take responsibility in their own hands, I think is very key. Alister, I would like to turn to you. If we could just I'm
You're
sorry.
muted. Yeah, one
Oh,
more time,
yeah,
please.
I think I muted myself. Thank you. If we could also return to this question of barriers and access, but with particular
Mhm,
attention to people of trans experience, folks who may be non-binary, non-conforming.
mhm.
Could you speak a
Yeah.
little bit to that?
Sure. Yeah, I mean, a lot of it really overlaps with the things that Sage was talking about, those social determinants of health, and that we really need comprehensive programs. Because, like you said, if someone's in a domestic violence situation or they're homeless, they're not worried about, taking their meds every day. So that's huge. And the other thing is having trauma informed and gender affirming healthcare practices that trans people feel safe, returning to. And there's a lot of barriers and limitations, which leads to poor experiences and people not wanting to return, people, not trusting PrEP, not understanding the side effects because they can't stay connected and have, open conversations. And then I also think a big problem is, like when we started at Amida Care, there was no model of care, for the work that we were doing. And disproportionately, it's the trans women of color that we're providing service to and really trying to figure out, um, what they need by asking, but also, by doing research, which is frustrating because, trans people aren't identified in HIV surveillance programs. There's very little studies. A lot of times, models of care are done on, one group and then applied, to trans people. So it's very ineffective. It's very limited. So I think that we need to do better at creating comprehensive, affirming care spaces and also increasing data collection. I think that people who are doing this work also have a responsibility to collect, congregate, and share data so we can all work together to make better programs that work for trans people, particularly trans women of color who are disproportionately impacted by HIV.
Yes, thank you. Thank you for making those points. Nathalia, I would like to come to you. If we could ask you a similar sort of question, just from your perspective doing harm reduction work, and then also just the same sort of theme, particular barriers for women, both, I guess, if you could talk about cisgender women when it comes to HIV prevention, and also non-binary, non-conforming, what you've seen from your work, that would be awesome.
Yeah, so I guess, some of the challenges I think are the same challenges that women, both cis and trans, feel engaging in healthcare. Some of those barriers can be mistrust or distrust or disbelief, and or just, you know, the numerous sort of socioeconomic barriers that make it hard for folks to access care. I think that at this point, there's plenty of research and plenty to show that a lot of times when women, both cis and trans, go to seek care or talk about their health needs, that they're often not believed, or their pain or their issues aren't taken seriously. So, it goes to stand that, when discussing sexual health, that they might not want to talk about it, one, or they might not be heard. They might not be heard in the ways that they're expressing themselves, the ways that they're describing their experiences, the ways that they're describing their relationship to sex, whether that's, through unconscious bias or stigma that they're coming up against. So I think that, a lot of the challenges that are faced, like that everybody has spoken about, aren't necessarily inherent to women, both cis and trans, but to the spaces that they're going to seek care, and that, a lot of the work rests on us. They have every right to not trust providers of all kinds. So, going in and starting to address all of these health needs that have been ignored or not heard for long periods of time would make a huge difference. I mean, even when you think about PrEP, how it's advertised on TV, on ads, how it shows up, it's not advertised for women. Even thinking about the newest drug, which I think was Descovy.
Yes.
That again is released but hasn't been studied.
Yeah.
Well, at least in that case for cis women. So it's really hard, I think, with, coming up with against that kind of advertising and against that kind of portrayal, to build that relationship and build that trust that would foster that increase in access. So I think there's a big amount of responsibility that falls on service providers.
That makes complete sense. And I guess before I had a question, but that begged one that I want to just pose to the group. What other pathways for communication, like the non-conventional, traditional ways to communicate with communities that don't trust medical providers, rightly so, given a history of malpractice, what ways could service providers be more intentional about messaging to these groups? And this is for any, yeah, Sage, go ahead, please.
Just wanted to say, here in our experience at the center, what we found is that our participants who have access to good behavioral health options make good behavioral health choices, and it's pretty skim, the places that we here as a center have to be able to refer people to get a good therapist in the Bronx, or good behavioral health professional that is that's basically conscious and competent to the need of the community, whether it's cis or trans or anything. And a lot of times these things are framed around the health insurance I have. And if I need to find a behavioral health professional, do they accept Medicaid? And if they accept Medicaid, how long is that waiting list? And do I have to go through a big process to be able to see them? Do I have to do like 3 intakes and go through a receptionist that probably hasn't been properly trained? When I go to the pharmacy, is the pharmacy going to know what this is for? Or they're going to stigmatize me or address me in a certain way for getting this medication? Or they're going to know that this needs to be prescribed in a certain way so that my insurance will cover it and I don't have to pay one copay as opposed to the other. And again, these are the experiences that come back to us. So we found that, addressing the participants' needs around behavioral health and finding a way to funnel them to the most competent behavioral health professionals has really been helping and elevating people's adherence to this kind of treatment.
Complete sense. Thank you for sharing. Alister, could you please add?
Yeah, I just wanted to add on what I was thinking, and someone actually commented about it, about like outreach and having boots on the ground and seeing people that reflect you. And I think another big thing, we can do is hiring and promoting community members and making sure that they're involved in doing the work. I mean, Amida Care, trans people trust us, even though we're healthcare insurance, which is really weird, to be honest. But like, we've done an insane amount of trainings, and our trans programs are led and staffed by trans people. And that makes a huge difference in developing trust and being able to have honest conversations. And so that when we do a risk assessment, people feel safe to tell us, what's going on, so we can connect them to the appropriate supports. If we can't have those honest conversations, it really limits, the support and the progress that we can make.
For sure. Thank you so much for emphasizing that point. I saw that as well in the chat. Dr. An, I would like to come back to you if I can, and just also get a little bit of a definite breakdown between PrEP or pre-exposure, and then also PEP and post-exposure. And so if you could discuss a bit about the benefits of PEP as well, for folks in our audience who may not know it, and the difference between the two, but how they're both out there as resources for folks if they ever need it.
Sure. So PrEP is when you're trying to prevent HIV infection and the person is not HIV positive. So the patient is HIV negative. And you may have an exposure, but we don't know. So when you do post-exposure, that's a definite. Like, for example, I'll give you an example, because we'll talk about a situation that happens is somebody you were with intimately calls you and says, hey, I just found out I'm HIV positive. So you definitely engaged in sexual activity, and that person definitely has HIV. You are not on any other medicine. Now you need to be on post-exposure prophylaxis because you definitely got exposed. So that there's the time is of the essence. So you should go see a provider within 72 hours as soon as you find out from the last exposure, because the efficacy or effectiveness goes down the longer you wait. So the longer you wait, it's not good. So if you find out immediately, or you think that it was a high risk encounter and you're not on Truvada to prevent infection, you should get the post-exposure prophylaxis, which is for basically about a month. Usually it's 2 drugs. The combination can vary depending on the regimen the facility is using. And you would basically also, a lot of times it's with urgent care or the emergency department, because maybe you don't have access to your primary care, but you do need, time is of the essence to get those meds, because the efficacy drops as the time lapses. So, and then they would draw blood work and do like STI infection, just the baseline blood work, and then follow you over a course of a month. And then even after that, after the PrEP is done and you're HIV negative, they will periodically also check your HIV and also do routine STI or sexually transmitted infection, screening again. And then maybe now you would be an excellent candidate for PrEP. Now because now you're negative. You had an encounter that was, very stressful, but now you're negative, and now you're an excellent candidate for PrEP, pre-exposure prophylaxis. So that's basically, in a nutshell, like what it is.
Yeah, thank you. You explained that very clearly, and the connection between the two.
Yeah.
I want to.
So it's basically it works in synergy. So you could go back and forth depending on what the exposure was.
Right. It makes complete sense. And the best way to access PEP would be to reach out to your local community health center post-exposure or just any pharmacy, Walgreens? Like, what's the best way to do that?
Oh, if you, unfortunately, Truvada and Icentris, which is a very common PrEP regimen, PEP measurement, post-exposure prophylaxis, it's very expensive. And for a community health center, like even Union, it's hard to keep in our pharmacy, which we have, because they expire. And then it's so expensive to get, and nobody it's hard to basically fund this streamline of Icentris and Truvada and have it available, because you want to give it right away, the first dose I'm talking about, and then we write a prescription for 30 days. So this is the tricky part, because every time, and we've had challenges like this. The good news is we partnered with Medley, which is our 340B pharmacy, and they're going to basically have available for a PrEP, the first dose. PEP, I'm sorry, PEP and PrEP. They're going to help us have those first doses, so we could start the meds immediately, as soon as possible, and then prescribe the medication. If it's a PEP, it's for 30 days approximately. If it's PrEP, like Truvada, it's going to be, until the risk is gone, or you could continue to be on that for, many, many months, depends on, the
Awesome.
situation.
Thank you. Thank you for explaining that point. I want to pose a question from the audience. This is for whoever feels comfortable answering. Hopefully we can get a couple different perspectives, but how does immigration status, or perhaps being undocumented, impact one's ability to access PrEP or PEP? HIV.
Actually, Union Community Health Center is a federally qualified health center. So we see everybody, including people that don't have insurance, undocumented, uninsured. You will be able to, we will work with the pharmacy and Gilead to get you the meds that you need. It's always a challenge though, I have to say, because it's not like, it's all readily available, but we do work closely with Medley Pharmacy, as well as we will reach out to Gilead to see if we can get medication for our patients. The funny thing about it is I still feel like there is a barrier because a lot of people are not coming in for PrEP for, I don't know what, for whatever reason. Because we do have a walk-in clinic. It's sort of like you could go in, you don't need an appointment, and people do come in. About 10% of the patients walking in come in for sexually related problems, I'm going to say. But I talk to my providers. I don't know if the patients don't feel comfortable because they don't know them. They don't really sort of, you know what I mean, engage in the PrEP right away. Even though we've had in-services with our providers, but I don't see huge numbers of PrEP, but being prescribed. It's not that the providers are not willing to do it. I just feel like, I think there's a little bit of inhibition on both sides. The patient doesn't feel comfortable talking about it. And the patient, probably a provider also, it's actually a sensitive topic. And you have to trust the provider, and also we have limited time. Sometimes we feel like time constraints for definitely our walk-in clinic, it tends to be busy. So I think it's multifactorial, but there's lots of this going on. But I think we just have to break down the barriers from education and just knowledge, and not be fearful of talking about basically sex in general, the types of sex, who you have sex with. I think I'm getting older because I feel like I have a teenage daughter. When I talk to her and her friends, I feel old. Because, it's just, I think they don't want to talk to me either. So it's just kind of odd, even though I bring it up all the time. And definitely I have patients that are on PrEP that I've seen, and it's the mutual trust thing. And I think the barriers have to be kind of removed. There's many barriers. You touched about many barriers. It's economic, it's educational, it's just access. They don't feel like they've been treated patients don't feel like they've been treated properly. So there's so many factors involved, and it doesn't help that we don't have a really comprehensive nationalized health care. It's very fractured. So that doesn't help because many times when you're talking about PrEP, or it's a very complex topic. It has many implications. And unless you address all of those things, you're not going to have a patient that's fully engaged to be able to take it properly. Because if you don't take it properly, the effectiveness is diminished. So that's what it is. You have to follow up, and you have to unfortunately see the provider when you first start engage with, this is PrEP. You see the first provider, they draw baseline blood work, talk to you about counseling, about safer sex counseling, side effects, adherence. Then you might see them at 2 weeks, then at 1 month, and then every 3 months, give or take the protocol and what your risk factors are to continue to take Truvada. So those are a lot of checkoffs.
Right.
And it, if you have housing instability or other challenges, you're much less likely to be able to adhere to the protocol. And if you don't adhere, you have to start over again. And it also puts the patient at risk. And the providers may not want to give a 90-day prescription because they haven't seen you in a while. They haven't had the blood work, because they don't want to give you medicine if you're having issues with your kidney or your liver. You don't want to give the medicine if you haven't seen them in a while. So there's a lot of different things, angles.
Right. No, thank you for sharing all of that. What it sounds like is that there must be other entry points when engaging folks about HIV prevention and PrEP, aside from explicitly talking about the drug, because folks are worried about like a shelter or food for their family, like common things that people shouldn't have to be worried about. And so finding ways to talk about sexual well-being and PrEP as prevention, as preventative mechanisms through a conversation about these other more pressing things, I think is something that we're all kind of getting at, touching on. And so I just wanted to name that. Before I get to another question, I saw Giselle Diaz had her hand raised. Would you like to say anything? You're now unmuted.
Yes, hi. I just want to add to the question you recently asked, and it's about the barriers in the Latino community. It's not only the stigma, but it's like we call it the taboo. Living in a family home that you are one thing there, but when you get out, you're something else. So there's a lot of things. And if the patient comes in here, we have to make them feel that they can be themselves as soon as they get into the clinic. It's not that I'm assuming, hey, because I see that you look like a male, you're a male, that's how you feel, la, la, la. It's also as like, hey, I would like to know you. How do you feel? What are your pronouns? Where are you right now in the step of your journey, as of like, are you feeling this way, or is this the way that you would like to be dressed at? Things that I hear in the Latino community is either, if I'm going to start PrEP, how can I hide it from my family and friends, or where I live in the roommates, and to make sure that they don't know that I'm on PrEP. That's another thing as a barrier for them to adhere to the medication. And I wanted to add that out there.
Thank you. Thank you so much. And so powerful what you just said. Some of the things that we're not discussing or just aren't privy to. Appreciate that. I want to, before we have an activity that hopefully will get more engagement from the audience and reinforce all of this knowledge that we've been gaining and discussing. But this is a question for all the panelists. How has COVID, or I guess like virtual service provision, either highlighted new avenues to get engaged with the community? Are there lessons learned from trying to pivot and work in this new world for the past year? Things that we want to hold on to as we re-enter, maybe things about access for folks who are not as able. Does anyone want to comment on any of those lessons?
Yeah, I would like to jump in.
Sure.
I think that there's a lot that we have learned in terms of accessibility. Like I have known some providers that have done things like this beforehand, but especially when I think about the substance use community, the DEA changed so many rules and regulations around methadone, around buprenorphine, around telehealth prescribing, so quickly, that allowed folks who, previously could not access a medication to access it. So many screening things were sort of put on hold. So many people who, maybe couldn't go to a clinic were now able to have medication delivered to them, or go to telehealth appointments, or be provided a phone to go to telehealth appointments. And so, as a couple of folks have already mentioned, sometimes it's difficult for folks to go to appointments every 3 months or meet those requirements. And I know that before COVID, I knew some providers who, might forego an appointment and leave some standing labs there for folks to just drop in when they could, and have that be, in order to get refills. But especially if we are looking to, make it easier for folks to get it, removing a lot of those restrictions would go so far in terms of allowing folks to keep up with their medication, be able to access it. We all are I'm sure very familiar with how many issues pharmacies can give when they're out, or there's poor communication, or whatever happens. So having the ability to just have prescriptions be refilled without a lot of questions, or sort of just smaller check-ins, faster check-ins, different avenues for folks to check in with providers would go really far. I think that's a huge lesson learned, both in the amount that we can do virtually, and also how quick a lot of the policies can change. Having a methadone delivered was something that I feel like folks had never thought would ever happen, just because it's federally regulated and it's so complicated to shift policy like that. But it was shifted, in a couple of weeks. And so I feel like we can never settle for that type of slow change ever again.
Right. No, for sure. When folks say that that's just not possible, it's obvious that it was possible, just with enough pressure, applied pressure. Does anybody else want to touch on this point before we go to the activity?
Yeah, so I'm going to agree. COVID basically was really a terrible thing that happened to us all, causing tremendous death and sickness. But it actually fueled rapid change in healthcare that it would have never happened this quickly. Just for even Union Community Health Center, we were interested in doing telemedicine, and it was sort of like a year program from March 2020. But as soon as the shutdown happened and we had no access to our thousands of patients that we had to take care of, that they needed their diabetes medicine, hypertension medicine, the psychiatric medicine, of course, even PrEP. We implemented telehealth in 2 weeks, I want to say, instead of a year. And it was very good for our patients. And yes, we basically had standing orders for labs. So we did virtual visits. First it was telephonic, and then now moving more towards the audiovisual or the video visit. But it's definitely changed healthcare, not just at Union, but just overall throughout the whole entire country. I would say for the better. It has better access, even though there's still limitations, because you would have to have Wi-Fi at home for the patient. If you don't have reliable Wi-Fi, then we really can't do a video visit. It's difficult.
Right. So definitely some work to be done still, but definitely some strides in the right direction, it sounds like. And a perfect opportunity, I think, to sort of reinforce all this knowledge with a quick little activity. And so if Sandrine or Alex, the folks could put up the poll, there it is. So it's 6 questions, true or false. We ask folks in the audience to take 20 to 30 seconds, answer these prompts, and then afterwards we'll go over it together as a group. Awesome. So I think we're starting to see some of the results. Can folks see the results on their screen? Yeah. Awesome. Okay, so I'll take the first prompt. I'll read it aloud and give the right answer, and then hopefully we can round robin style this. So the first one is true or false, PrEP makes individuals more promiscuous. This is a big false. There's nothing in PrEP chemically that makes one more promiscuous. I don't even know if that's possible, I guess, outside of aphrodisiacs or some like modern myth, but PrEP does not make individuals more promiscuous. Alister, do you mind taking the second one?
Okay. Yeah, so number 2 is true or false, PrEP can interfere with hormone replacements. So that is a capital F, false. There are no known side effects with taking gender affirming hormones. We found when we were doing our HIV risk assessments that was, we were collecting information on why people decline or aren't interested. The number 1 was people don't see themselves at risk. Number 2 was they're worried about it interacting with their hormones. So we're working on educational campaigns to dispel this myth because it definitely limits access to this one for sure.
Thank you, Alister. Sage, number 3, true or false? Once you start PrEP, you can't stop. Do you mind answering that for us?
So, number 3, true or false? Once you start PrEP, you can never stop. I have false.
Yep.
Basically, you can stop or start at any time. The importance is the consistency while engaging in risky behavior.
Exactly. So although it's required to regularly take the medication for it to work, there's no requirement that you must be on it once you start. Dr. On, do you mind taking number 4?
One last thing I just want to add, if you want to stop PrEP, I wouldn't just stop it cold turkey. I would discontinue it. I would take it for 28 days after the last high risk exposure that you think you had. So that's the only caveat or consideration, that you would want to take that for 28 days after the last, questionable or you're concerned about relationship.
Mm-hmm. Thank you for clarifying.
Sure.
Do you mind taking number 4? True or false? I can take PrEP only the day I'll know I'll have sex.
No, you take it all the time. That's the most common regimen. There is another regimen, the 211. That's an as needed PrEP. It's not as prevalent or prescribed as much, but there are people that are considering it, or maybe some providers are thinking about it. It basically, you take 2 Truvada, 2 to 24 hours before you have an encounter. And then 24 hours later, you take 1 more Truvada, and then 24 hours after, you take another one. That one, I have to say, it's there's a lot of hand holding, and also I feel like the compliance and it may not be as good. It's almost, I would say, routine is usually you get better compliance, but there is that other regimen for some people that have a different, I guess it's always something that is an alternative, but it's not as widely prescribed. The regimen daily is the most common regimen that people are prescribing today, which is 1 daily pill.
Yep. Awesome. Thank you. Thank you for clarifying. Nathalia, if you could do number 5.
Yes, so true or false, I don't need to wear condoms while on PrEP. So that is false. So depending on the type of sex one is engaging in, PrEP does not protect against other STIs. So wearing condoms or using other forms of protection with sexual partners can protect against other STIs.
Thank you. Thank you so much. And I'll wrap this up. True or false, PrEP has no side effects. So this is false. there are short-term, more common side effects such as nausea, diarrhea, and headaches, but they usually don't occur. They only occur around commencement, and there are fewer long-term side effects, and these are much less common. I just will name that they are liver and kidney damage, bone density damage, but again, way less common, and those are like the long-term side effects. So you can expect perhaps to feel some nausea, diarrhea, common side effects when you are getting on, but these are all questions that you should be having with your primary physician or your local MD, somebody at your local community health center who can provide comprehensive clinical perspective. But that's basically it. Thank you all. We have one more for engaging in that activity. Just have one more slide that we want to put up, and it's local resources for folks based in the Bronx. A little bit from AmidaCAAD, the New Pride Agenda. I think some of the organizations folks on this panel are representing. And so as we wrap up, I just want to put this up on the slide and take an opportunity to take any final thoughts from any of the panelists, or if anyone in the audience has anything else that they would like to share. Before we say goodbye to each other until our next virtual town hall on PrEP. Awesome. Well, you see this information. Of course, this was recorded, and so please keep an eye out for a recording from New Pride Agenda's team and our YouTube page and our website. AmidaCAAD, I'm sure, will also be sending things around. I want to say a deep thanks to the panelists, Alister, Sage, Dr. An, Nathalia. It's been great to learn from you all and share this space discussion about an important issue. Also, the Councilmember Gibson, thank you so much for starting us off on a great note. And of course, you all who have been watching, making this an engaged and lively discussion. I appreciate it genuinely. And thank you to Shakira, Sanjurine, Alex, and the tech team for hitting us off so smoothly. It's 1 o'clock. The sun is shining. I hope everyone gets to enjoy the day a bit, get a walk in or something. But I wish everyone the best, and hopefully we'll see each other soon. Take care.
Thank you so much.
Thank you, Ahmed.
Bye-bye.
Thank you.